The lack of information is a public health crisis. Corporate capture is a public health crisis. Our system is in a public health crisis.
At the end of the day, as long as I know there's a profit incentive attached to anything in public health, I'm always going to have a degree of mistrust.
I look at some stuff and go, well, you're affiliated with people that are like pushing ineffective or harmful supplements and medications and making tons of money off of it.
Probably the one area where there is a consensus in the MAHA community is that, yes, vaccines are a good way to prevent the spread of infectious disease. That being said, I think safety is where people have some questions.
I think COVID vaccine should have been like COVID vaccine asterisk immunobooster or something along that line. That way it wasn't just straight up a vaccine, because when people heard polio vaccine, I got a polio vaccine, I don't get polio. But with COVID, I got the COVID vaccine, but I can still get COVID.
I think in many ways it was one of the greatest scientific or medical achievements in our lifetime. I think where we failed to explain what this vaccine could or couldn't do.
Then why didn't you know that this treatment would not stop transmission, would not stop infection? But you told us that it would. And then, we were vaccinating 12-year-old children who were then going to visit grandma with a loaded gun.
I think that was where you had your community group and your individual group kind of start communicating, I guess, like, do we trust anything? I think that's where it kind of came along.
Elizabeth, did I answer your question? Do you feel like when you look at me, you don't feel horror anymore, or you still feel the same level of horror you did before?
Well, I never felt any horror, Paul. I can promise you that. I've always been of the mind that we are all working toward a common goal, but sometimes we just get caught up working against each other.
Maggie Bartlett. Welcome to Public Health on Call.
Thank you so much. Oh man, I said that so loud. I'm so excited.
We're very excited to have you here with us live. Would you tell us a little bit about you and your work?
Yes. So I'm a virologist. Really, I got into virology and pathogens out of a place of fear. So I had obsessive compulsive disorder as a kid, and I was really scared of everything. So to understand that better, I really turned to logic. And spent time learning about the things that were scaring me, from antibiotic-resistant bacteria to brain parasites. And I found a passion for research and answering questions that we didn't have answers to. I ended up doing my dissertation on the differences between humans and bats with hemorrhagic fevers. And during this time, I started to get really interested in the persistence of viruses, so they can hide places and then recrudesce later. And so when I was thinking about my next career path, of course, I wanted to continue that. And I did my postdoc here at Johns Hopkins with Dr. Diane Griffin, who was a tremendous mentor and just a leader in the field of virology and neurology, viral RNA persistence. And she really let me focus on things that I was passionate about within her scope. And I'm really grateful for that. And so we started to have a pandemic. And as a virologist, I wanted to help. We ended up doing a lot of assays in the lab, tests to look at the levels of virus in blood, look at the antibody levels, look at different cells that were responding. And at the same time, I was dealing with my own health struggles. I have a chronic health condition. And as we were working on these, I couldn't help but see overlaps. And Diane was so supportive of me wanting to expand my research portfolio. So I actually recruited my geneticist and some of my doctors at the time to let me work on some of their projects. And we ended up being able to prove that people who have a hereditary connective tissue disease were at higher risk of long COVID. So now I'm starting up my own lab as an assistant research professor here, which feels surreal, looking at that interplay. So viruses and how they get to the brain, what happens there, and in the genetic background of somebody with a connective tissue disease, how does that differ? Because ultimately, if we can understand that, one, we might be able to offer better treatments, but two, people could prevent potentially getting those infections and having chronic comorbidities that we just kind of associate as part of the pathophysiology there.
And now you've you're wearing a new hat. Just in the last 6 months or so, you've joined this new podcast called Why Should I Trust You?
Yes.
And you've really taken a leading role on public health communications. Tell us about, this new role that you're playing.
Yeah, so I never wanted to be visible at all. I wanted to hide in my lab and study viruses, but I couldn't sleep. I was thinking about avian influenza over a year ago, and it had all the same hallmarks of what happened in the market in Wuhan for SARS-CoV-2. And I really wanted to believe we wouldn't be in that situation again because we had this experience. We have the tools, the technology. We never have to have a pandemic again. So why are we not applying those? And I was watching Jon Stewart because I couldn't sleep, curled up with my cat in the glow of the TV. And Brenda Adhikari came on. And if anyone's listened to our show, she's one of our co-hosts. She was explaining something to Jon, and his mind was blown. And so was mine. And there was just something about her that I thought part of why we can't apply the lessons is we're not communicating to the public as well as we could be. And I need help telling that story. So I shot a message into the void. I didn't think she would respond to me, but she was curious. She was like, what's this virologist at Hopkins doing?
Yeah.
Messaging a TV producer. And we had a couple conversations and really hit it off. I visited her in New York, and we started talking about what does public health need to do. I was sharing with her the things I see and what I wasn't hearing from my family back in Nebraska. And she brought on her colleague Tom Johnson, who had worked with her for a long time, and then Mark Abdo-Malik, who's a physician and our other co-host. And we just spent this deep period of time doing development of what is the biggest issue. And it really was trust. I faced that so often during the pandemic with family, with friends, just being at an institution, there was that distrust. And how you break out of that, you really have to rebuild it. And so they said the way to do that is a podcast.
To start a podcast. That's what
start
you
a
do.
podcast. So the way to get the information out there and to build that trust is to hear people and really communicate with them in a way that you understand where they're coming from. And I think that we do that pretty well as scientists, but not very well in public spaces. And so that's where I feel like their approach has been unique, because if you told me when we were starting this that we'd be talking about some of the things we're talking about, I wouldn't have gone for it.
Give us an example.
We've had a lot of really fantastic conversations with the Make America Healthy Again movement from different places. Ohio's one that we've talked to a lot. But having people on who are vaccine hesitant or anti-vax has been challenging. And hearing people where they're at, I can completely understand now. And this is the brilliance of Brenda and Tom, is that it's this human element that they're bringing in, and that I can hear people and in some ways be, a person in public health saying, yes, yeah, there are things that happen. There are side effects with vaccines, but they're our safest tool. They're our safest therapeutic. And so when people come in, especially when there's, misinformation, which I now know is also a red flag word for a lot of people.
Yeah.
And so I'm learning so much about even the language that we use immediately turns people off to listening. Then it becomes so hard of how do we share the evidence if we've lost them in the first sentence?
How do you use the right words that are the correct words when those words are off-putting, or those words just immediately send up a brick wall?
Yeah.
I remember there's one particular conversation in your podcast where there's a discussion around whether or not the COVID vaccine, I'm going to broadly say, works.
Yes.
And is it an immunobooster? And why are you not calling it that? Why are you calling it a vaccine? And if you had called it an immunobooster, if you'd called it that from the beginning, I might not have my hackles up the way I do now. And that conversation, it got a little boxed in.
Yeah, it did. Yeah.
So, where do you go from there? And it's like, okay, well, there's different kinds of vaccines. Some of these conversations, it feels like, okay, we've gotten it out in the open. We've opened the blister. All this stuff has come out. Where do you go from here? How do you heal?
Yeah, and that's been what's so fascinating to me about it in this process is it was never going to be one conversation, and it's never about us convincing anyone. And that's how I show up. I'm the virologist. I bring in my expertise, comment when I feel like commenting, but my role isn't to debate anyone, to convince anyone. If people bring up things, I can bring up, evidence and share, but ultimately they're coming in from their perspective, and they may have seen an entirely different portfolio of data than I'm privy to. That happens all the time. They bring up, this or that, and I share, a peer-reviewed publication, but they're not getting access to that. I have access to all these journals.
It's behind a paywall half the time.
It's behind a paywall.
Yeah.
So how could they have that information?
Right.
And some of this really hits on we need so much more scientific literacy in education, because that point of don't call it a vaccine, I'm like, well, it is. But it brought up another point of like, how well are we addressing these things?
Yeah.
We're in such a different environment now than when I was going through school. The information barrier is so different.
Yeah.
And so how do you address that? And I think that's where we're at, this kind of like community level building of trust. So when we speak to people in Ohio who are MAHA affiliated, we bring in local public health people who have a tie to Ohio. And similarly, wherever we do those conversations, bringing in someone who's local, because that was the other thing that really was surprising to me was people didn't have a point of contact during the pandemic of this is somebody I can get my information from. This is someone in my community I trust. Because public health professionals weren't front and center. They didn't have campaigns in their town to tell them who they are.
Yeah.
Because ultimately, if we're doing our work effectively, you never know.
Right? It's invisible.
And
some of the figureheads, like, a public health person that's in a position of authority in a town, like that was highly politicized.
Yeah.
And, some people received death threats because they suddenly became the figurehead of everything.
Yes.
Like, how do you have a conversation when you've got a mob that wants to hurt you?
That was one thing that I also found so interesting was that the people who were scaredest to talk often were the people on the public health side. So experts were afraid to enter these conversations. I was afraid. I was like, what am I getting into? What am I opening myself up to? But also, you care so much about all these people.
Yeah.
You want to make sure they're feeling heard. You don't want to be another reason why they're just going to turn off something in science. They're not going to support something because you're part of that problem.
What's really surprised you about these conversations? It sounds like you're learning a lot from them. Maybe we're hearing each other out, but like, what's really surprised you?
I would say I'm very surprised by just how friendly the conversations have been, especially because we do talk about some things that normally I think people avoid talking about. And we're able to come in to these Zoom rooms, hopefully in person soon, and have these conversations where everybody kind of shrugs that off. And Brenda always opens it up with like, this is a dinner party. We're going to have fun, but if you step out of line, I'll take you aside.
Yeah.
And nobody's yelling at each other. We've had such like really interesting pieces that have come out to me, like where people get their information, who they listen to, what misconceptions they had going into it. I think there's so much work that's happening on the shoulders of everyday Americans that it's impossible for them to find the truth sometimes. Like when they're describing what they do to like chase down news, I'm like, man.
Yeah.
That's exhausting.
And it's really hard to name call when the person sitting across from the table is like, I'm actually not in pharma's pocket.
And that's been so fun too. Like Dr. Paul Offit has joined us a few times.
Yeah.
Somebody brought up that they thought he was a demon.
Oh no.
And he's the loveliest human. And he went through, like his inception into medicine and what made him want to go into it. And by the end of it, we asked, like, do you still think he's a demon? And they were like, no.
Yeah.
But all they had seen of him was this caricature,
right?
This, basically a pile of tweets and other things on the internet that have characterized him that way. And we had him walk through, how does the pharmaceutical industry work with research? Because most people don't know. I didn't know before I was in research. And I feel like we also don't do a good job of explaining that or what role the NIH played. Because he did most of that work for the rotavirus vaccine through NIH grants, and it was decades of work. And by the time they were going to take it to market, it wasn't like he sold it and he's a billionaire.
No, he said, this is a one and done vaccine. I should have come up with a medication you have to take every day. Then I'd be rich.
Yes, yeah. And at the end of the day, it's not him.
Right.
The institution is the one that relationship goes through. And so I think there's also just a little bit of, us being better at explaining what our jobs are, what our ethical frameworks are. Because I think we do that so well. And when this became a main thing that those we were talking to wanted to talk about, corporate capture, I was like, well, vaccines aren't historically what makes them money. But when you say that in lieu of what happened during the pandemic, money was made.
Right.
But when you look at that compared to antivirals or other therapeutics, there's a discrepancy there. And I also feel like just being able to talk about that more openly and explain, as a researcher, I can get funds from a company to do research, but they're not telling me what to do.
Right.
I'm telling them what I'll do, but that process isn't clear to anyone outside of where we're working. And so that was interesting to hear how people see it versus how I live it. When I'm reviewing a paper and someone says they have advised a company, I don't assume everything they're doing is for that company.
For the benefit, yeah.
Right.
And if you want to look at it another way, the opioid epidemic, it was a huge contributor to this conversation.
Without a doubt, that is the other thing that surprised me most, is that when we ask people, what led them down, this path, why do they support this person? The opioid crisis is by and large the thing that stimulated most people to start thinking more about health and what the government's doing to help.
Pharma.
Yeah, big
and
pharma.
It predates COVID.
Oh, yeah. It was all of these things. I think COVID was probably the flame. It sparked it, but we were building up to that. The opioid crisis, the turning away from primary care. People didn't have a go-to primary care person or care team. Or a lot of people we talked to, one of the things that made them want to look at more of their own research was an experience in a doctor's office where they felt dismissed.
Yeah. And that's understandable.
Oh, yeah.
And they're looking for answers. And I think, especially for a lot of different reasons, the wellness community has embraced these kinds of questions. And this is all just a perfect storm. I asked you, what has been surprising about these conversations? Where do you feel discouraged?
I feel like we have to do so much work to build trust. And when I sit down and think about, why should someone trust me? And that loss of trust, that kind of nihilism has gone so deep that I worry about our ability to come back from it. At my core, I'm an optimist. So I think we can, but there's always a reason to distrust someone. Trust but verify. We got to this point, I think, in science where the data will speak for itself, but it does not.
Yeah. And my fear is that the data that we may hear from or revisit in the future is not going to be good data, in the sense that it's going to be consequences of what's happening now. It's okay, well, now the data is very clear of what happens when you don't have vaccinated children. You know?
I mean, I think that's what sticks with me, because I've worked on measles virus, and for us to cross the number of cases we've had is harrowing. To have over 3,000 cases is unprecedented. It's because of the drop in vaccine rates, which is a lot of different reasons. But measles, you need above 95% to have protection, and pretty much every state is below that. So it's not surprising what we're seeing. But I feel like one of the things that we're not often addressing from a public health standpoint is that in 5 to 10 years, 1 out of 1,000 kids that get measles right now and were unvaccinated are going to have a terrifying encephalitic event. when you have acute infection, it knocks out your immune memory so that you are less likely to overcome another infection. That's why most of the deaths are related to pneumonia or something else. Most children do survive, but 1 in 1,000, 5 to 10 years later, the virus is still there. The virus is in their brain and it reactivates and it does damage. It kills cells, it causes brain to swell, and is almost universally fatal because we don't know how to predict it for patients. So your child can overcome this acute infection fine. But 5 to 10 years later, you could lose your child. And it's like a train coming in. Like there's no protection. Mm-hmm. And we're not doing enough research to understand it because there were so few cases.
We didn't need to.
We didn't need to.
Yeah.
But in 5 to 10 years, we have enough cases now. We will start to see this. And we also don't know, the infection in childhood, what that changes in your immune system for subsequent pathogens. We know it knocks out your immune memory right afterwards. It makes you more susceptible to every infection for the next several months, which is not ideal. But we're also at this interesting period of time where we have SARS-CoV-2. We have new variants all the time. We're seeing new pathogens all the time. We can't really apply things that we did previously in the same way. We know more. We know more about exposures. And so there are these things that I think we haven't applied, especially for viruses that can get to the brain. While it's not all the time, for those cases where it does, it's lethal.
It's devastating.
Or it can cause chronic conditions. So that infection, if you have acute measles infection and encephalitis, that can cause damage where you then have cognitive difficulties. And in pregnant people, it can lead to developmental issues in their newborn child. Like it has these ripple effects that go beyond a rash.
Just to turn a little bit, what makes you hopeful? You mentioned that you're an optimist. You're engaging in these really hard, necessary conversations. What makes you hopeful?
Yeah, I think what makes me hopeful is that when we have these conversations, everybody is so engaged. I don't want to say both sides because I really see so much overlap between public health experts and the people who are passionate about making America healthy again. Most of my colleagues who've been in public health have said, we've been wanting this. We've been saying this. So I think seeing those commonalities gives me a lot of hope because there's things we can work on to a greater good.
Yeah.
And I think also just the willingness to be humble and be in those spaces, even if they're uncomfortable, has been really astounding. Like just to have people reach out and say, hey, I listened to this. Here are some of my thoughts. I'd love for you to talk about this. I thought this was really interesting. And we get that from people who are Make America Healthy Again, from people who are in public health, from people who aren't on any of this, but are just listening.
Yeah.
And so I think that it's tapping into a hope that we all have, which is that we can have a better existence.
Yeah. I mean, this isn't just like, we're going to create a scenario where, Maha, you gain access to public health people. You get an hour. Ask them whatever you want to ask them. This is everyone in the room just wants to be understood, wants to be heard, has concerns. Everyone in the room, like ultimately, we all kind of want the same things. We're just coming at it from different backgrounds. We're asking the questions in different ways. We want accountability when it comes to our health. We want, autonomy. We want our children to be well. And, I think it's really important to remember that this whole us versus them thing is kind of almost like speaking different languages, and you're trying to come together and find a commonality there so you can figure out how to work together to make these things happen.
Yeah, because that's what all of this is built on. I wanted to understand how to talk to my family back in Nebraska. I wanted to understand how to talk to anyone about pathogens. Pandemics aren't inevitable. Outbreaks are going to happen. Spillover events are going to happen. Pandemics are a choice of our society now that we have tools, technology, and expertise. And especially when I'm seeing things like post-viral syndromes being this huge concern that we're not fully addressing, it's so in line with Make America Healthy Again because many people are suffering from chronic conditions caused by an acute viral illness. We just don't know that yet. We know it for long COVID.
Yeah.
We suspect it for many others, but we've never had the test like we did for long COVID. But there's multiple different pathogens that can cause this. And we just didn't have the tools before. We're in this kind of interesting explosion of data. And so being able to just sit in that and figure out which path to go down, I think is really inspiring. And all the early career people that have reached out to me, I'm starting my own lab. This is a whole extra thing.
Yeah.
But there's a new way for us to do science communication. I think, again, I'm saying this to someone who does this very well. But we need to be integrating that more.
Sure.
I didn't have any sort of course on communicating my science to the public. I did a lot on communicating to other scientists. But there is a real need, and not everybody has to do it. But we need to be giving people who want to do it the tools to succeed, because we need the next generation to be on TikTok, to put out positive, evidence-based, engaging content, because otherwise the only content that's out there is skewed.
Well, Maggie Bartlett, thank you so much for coming onto Public Health on Call and having this conversation. I mean, this has been great. People can find you at Why Should I Trust You? And we'll share some links in our show notes. Thank you so much for being here. This has been great.
Thank you so much for having me.